Well, thank you very much indeed, Ira. Good afternoon, everybody. It's a massive pleasure to be here again in Bern. Thank you very, very much for inviting me to tell you about what's been happening in the UK. So I come from Warwick, which is right in the centre of the UK, and I'm going to tell you a little bit about things that have occurred with hip arthroscopy in the last few years. Now, let me set the scene a little bit. A few years ago, we in the UK were criticised because we were starting to do a new operation, hip arthroscopy, for a new diagnosis, femoroacetabular impingement. And so, perhaps reasonably, the community felt that we didn't have any solid science behind this, nor did we have really clear definitions of what we were speaking of. So one thing we did was to agree in the UK what we meant by femoroacetabular impingement syndrome. And if you ever struggle to explain to your funders or your hospitals what exactly that is, you may find this paper useful, the Warwick Agreement, which you can download from the British Journal of Sports Medicine from 2016. And in it, there's a graphic like this, which shows the diagnostic criteria for femoroacetabular impingement syndrome. And you can see that we defined it as a triad of symptoms, signs, and radiological features. And we explained what the usefulness of imaging would be in that context and of diagnostic hip injections. But we did recognize at that time that there were a number of possible treatments for these patients. There were people who felt that conservative care, which was really analgesia, activity modification, advice, education, was all that was required. And then there were a group of mainly physiotherapists and sports medicine physicians who were keen on a physiotherapy-led rehabilitation program. And then finally, no surprise to most of you in this room, there were surgeons who felt that surgery was the right answer. And of course, some of those surgeons were keen on arthroscopic surgery and some on open surgery. But really, there was absolutely no idea of whether there was a different effect amongst these different treatments. And that was a problem for us in the UK because the Department of Health, who fund all of the healthcare in the UK through our state system, which is by far the biggest part, they were beginning to say they weren't going to fund hip arthroscopy anymore because we didn't have any level 1 evidence to support it. Now, any of you who've been involved in medical funding politics will recognize that as just a way of avoiding having to spend money. It's not necessarily a proper judgment as to whether a treatment is effective. But faced with that argument, we orthopedic surgeons needed to get some level 1 evidence in order to be able to continue developing this field. So we're faced with these arguments. Hip arthroscopy is a new cost, there's no level 1 evidence, and really the NHS, the National Health Service, perhaps shouldn't be funding it. So we lobbied the National Institute for Health Research to fund an appropriate study. And this was the question that they came up with after surveying the community widely. It's interesting that they chose femoroacetabular impingement syndrome as the test bed for hip arthroscopy. Perhaps it was just because that was the most common diagnosis being specified for the operation at the time. And they wanted a comparison of hip arthroscopy with best conservative care. So we did a feasibility study to see whether that was feasible. I think actually that the authorities had hoped that it would not be feasible to do this trial. In fact, they told us that they didn't think it would be feasible. They said that patients wouldn't be prepared to be randomized, and they also said that surgeons wouldn't be prepared to randomize patients. They didn't believe the orthopedic community could do it. But we showed that it was feasible, and so then they didn't really have any choice. They had to fund a full-scale trial. And that was run from Warwick with some colleagues around the UK and called FASHION, a full trial of arthroscopic surgery of the hip compared to non-operative treatment. So we included patients who were your typical patient that you would expect to benefit from arthroscopic surgery for FAI syndrome. So all adults with the usual radiographic appearances, and then most importantly, the surgeon felt that that patient would benefit from that treatment. We excluded people who'd got evidence of osteoarthritis or any important previous problems with their hips, and also people who'd had any attempt to change the shape of their hip by any means before. And then we had two interventions. One was arthroscopic surgery, and I think you're all very familiar with the techniques there. We did not specify very precisely how the surgeons should do it, but we said that there should be, at the very minimum, be an arthroscopy of the central and peripheral compartments, that the arthroscopy of the central compartment should address the articular cartilage and the labrum, and that there should be bony shape-changing surgery, either of the acetabular rim or of the femoral head-neck junction, or both. And we were asked to compare this with best conservative care. Now that was a bit tricky because the organization that specified this trial didn't know what they meant by that. So we had to work that out, and we came up with this program, Personalized Hip Therapy, which was really an international consensus of surgeons, physiotherapists, and sports physicians as to what the best you could do would be with a patient if you were going to manage them non-operatively. When I say best, I don't necessarily mean the absolute diamond treatment, but that you could do in regular practice in a normal hospital. And that looked a bit like this. So a 3-month program of one-to-one sessions between a physiotherapist and a patient, which was an individualized and progressive program. It began with education and advice, but then moved on to muscle control, stability, and strength and resistance training. So this is how the trial looked. It's a very standard sort of laydown for a randomized controlled trial with a one-to-one randomization in the center there. And our principal outcome measure was at 1 year, the IHOT33, the International Hip Outcome Tool. We also planned, and we are, measuring other things and at other time points right out to 10 years. Now, this needed to be quite a big study because we knew we'd only get one chance to do it. If we performed the study with too small a sample and we didn't get a convincing result, we thought we probably would be stopped from doing hip arthroscopy in the UK and never have the chance to do this again. So we wanted 90% power to measure an effect size greater than the MCID of the IHOT33, which is just over 6. And that meant we needed 344 patients. And this is how it went. So any of you who are thinking about doing a randomized controlled trial, you need to plan to commit about 10 years of your life to it. You can see that we started planning, I actually started planning it really in about 2009, and then really got working on it in 2011. And I'm presenting to you today some 2-year results, but we're going to continue collecting results for another 10 years. So in fact, in the end, it'll be 20 years of my life just doing this study. It costs a lot of money as well. So we've had just over £2 million, so close to $3 million US dollars to do this study. It's a very expensive thing to do. We worked in 21 hospitals around the UK, and these were all the hospitals in the UK, bar 3, where any significant amount of hip arthroscopy was being done. 26 surgeons took part, and all of these are surgeons who, as part of their practice, have a major interest in hip arthroscopy. They're not quite all fellowship trained, because some of them learnt to do it before fellowships existed, but they are people who really do a lot of hip arthroscopy and have had some formal training in the past. And then we had a large number of physiotherapists who we trained to deliver the personalized hip therapy. And we trained them in a whole bunch of classes. This is one of about 6 classes where we taught the physiotherapists how to do that. So some numbers for you. During the course of the study, we had 648 eligible patients, and 29 of them, we made a mistake and we missed them. but 268 of them declined. You can see the reasons they declined there. It was mostly that they preferred to either have surgery or no surgery, and they didn't want to be randomized. But compared to what had been thought at the beginning, that patients wouldn't be prepared to be randomized, you can see that more than half of them agreed to be randomized. So 348 patients were randomized, and it was roughly equal on the two sides. And you can see that 177 ended up having personalized hip therapy and 171 arthroscopic surgery. Now, a big potential problem in this study was that patients who were allocated to physiotherapy would decide that actually they wanted an operation. So in order to include them in the study, we asked them to agree in advance that they would stay in whichever group they were allocated to for a year before anything would change. And that worked pretty well. We only had 8% of the patients decide halfway through that actually they didn't want physiotherapy, they wanted an operation. So that crossover rate was acceptably low, much lower than some other studies that have been done of similar questions. And we achieved a pretty good follow-up, over 90% follow-up at 1 year. And that's been maintained, actually. That 8% that we lost, we've sort of lost them, but we're still keeping in touch with these 92%. So some results for you. You can see that if we do an intention-to-treat analysis, which is the purest and most robust sort of analysis, that is to say, we analyze patients for the group they were allocated to, recognizing that some of them may have changed their minds. But if we allocate according to intention to treat, you can see that at the beginning, the two groups, yellow for surgery and blue for personalized hip therapy, have the same IHOT score. And after 12 months, there's been a separation between the two. Both groups have got better, so both treatments seem to work, but the group who had surgery have improved more than the group who had physiotherapy. And the numbers behind that are here. So the raw difference between those two groups is 9 points on the IHOT scale. If we adjust it for all potential confounders, so we try and make it as small as we possibly can, we can't get it down below the minimum clinically important difference. It goes down to about 7 points. And the p-value is very low, so it's very statistically significant, as well as being clinically important. Now, at 2 years, what we're seeing is, following these same patients up, that there is a maintenance of that difference. It actually looks as if the difference is getting a bit bigger because the physiotherapy patients seem to be deteriorating. And that's maybe what we would have anticipated. Certainly, that was one of our prior hypotheses. But I don't think that we can see that enough yet to have confidence in it. But what we do see is that we're getting results that show that the difference is maintained. And the other big thing that's happened is that a lot of the patients who were allocated to the physiotherapy group have been frustrated that they didn't get better and have then had surgery. So 27 more patients out of the 177 in the physiotherapy group after the 1 year point have opted to have an operation. And what's going to be very interesting is to see how they do in particular. And we don't have that data yet, and we won't have it for another year or so. But you can see that patients who have physiotherapy not only don't do as well, but then many of them decide to have an operation afterwards anyway. So our conclusions have been that there's a clinically significant effect and a statistically significant effect of arthroscopic surgery in patients who have femoroacetabular impingement syndrome. In short, we think that this sort of surgery works. And this was the first time that we had any level 1 evidence that hip arthroscopy was effective. Now, that was published in The Lancet last year. You can download it for free and wave it in front of your hospital administrators if you need to. But what you might find also helpful is that there have now been 3 randomized controlled trials published of this question. The first one was in the American Journal of Sports Medicine. It was a small study. It had a massive crossover rate, and it showed no difference. Then fashion, which I've just presented to you, and finally fate, which was similar to fashion but a bit smaller, from Oxford, which also showed benefit of surgery. And Tim Dwyer published a meta-analysis of these last month, which shows benefit of surgery compared to physiotherapy. So now we have level 1 evidence, a meta-analysis of level 1 randomized controlled trials, which is the highest possible level of evidence that we could have. There's quite a lot of controversy, though. Don't try and read all of this, but that's just a Twitter argument that's been going on in the last few days about that meta-analysis, suggesting that it underestimates the benefit of arthroscopy. And you can see the sort of forest plot there at the bottom, where a reanalysis has shown that the benefit might be even bigger than that meta-analysis demonstrates. So there's quite a lot of controversy still flying around about this question. And the final thing to say to you is that fashion was done in the UK, but we've run exactly the same protocol in Australia. So on the left-hand side, that's the UK study in the NHS, and on the right-hand side, funded by the Australian government, a similar study using exactly the same protocol has randomized 99 patients and is now closed. Now, with our study in the UK, we'll be able to measure all sorts of things going forward, including eventually hip replacement rates. In Australia, my colleagues have got a very interesting outcome measure using Degemerik to try and demonstrate a change in the, or a difference in the development of damage to articular cartilage. And I know that young Joe is part of that as well. We're going to put these two studies together because they ran exactly the same protocol, so we can do an individual patient data meta-analysis, and we'll have that as soon as the Australian study is published later this year. So we'll have 450 patients in a single publication. And then finally, what we're really interested in is working out which patient factors predict benefit of arthroscopic surgery, and which patient factors predict that patients would be better off not having surgery and would be better off continuing with physiotherapy and conservative treatments. And finally, may I just add my invitation to that Paul gave earlier for ISHA, the International Society for Hip Arthroscopy and Hip Preservation, in Ottawa later this year. We had a fantastic time in Madrid last year. I know many of you were there. I do hope that I'll see many of you in Ottawa too. Thank you.